Good morning. You look so pretty today. Where are you going?
I have a meeting, um, so
You
I,
look like you're going for an interview. I mean, you look gorgeous. Between your hair, makeup, and outfit, I'm impressed. Not like you don't
yeah,
look good all the time, but I mean, I'm in like comfy clothes. So if I were to be
oh,
dressed up, you know what I
I
mean.
understand. I usually am. Um, okay, I don't usually talk about this. So I was elected to the city council here in Birmingham, and the meetings are on like Tuesday mornings from 9:30 to whatever. So now
That's
we've got this
fun.
mad dash because Dr. Cantor has moved our noon meeting to 7:30 a.m.
Oh shit. So your day today.
So it's just like jumping, running from like one place to the next. But it's okay.
What do
This
you
is the
do to
first
start your day though? I mean, you know me, I'm all about like mental health and stuff, but like that's an insane morning. And I know how mine, like, are you intentional when you wake up just to kind of
so this
center
is
yourself?
the first like so I just was sworn in last week. So this is the first like time of trying it.
Okay, cool.
Um
So it's all recent. That's so exciting. Congratulations. Did you get nominated? To apply for it? Like, how does that work? That's so
it's
cool.
a full election. So you have to like campaign and then there was a runoff and then it was just like a never ending.
But you got it. Wow, I'm so happy for you.
Thank
Congrats.
you. Thank you. So yeah, it's yeah.
Yeah,
So
see how it goes. But I would like literally when you brush your teeth in the morning, just use those 2 minutes to center
like
yourself and
center.
just prepare yourself for the day. And like I'm very intentional. If you can't tell, I'm very intentional, but there's like actually a scientific reason to be intentional because we have this part of our brain, the reticular activating system, which essentially explain it to my patients like Instagram algorithm. Like when you're on Instagram and you like certain things, you start getting more stuff funneled that way. And when we
Right.
set our day, setting an intention of how we want to feel or what we want to do, our
Mhm.
reticular activating system essentially is going to surveil our life
Adjust.
and kind of funnel information through that way. So if we can be intentional, use those 2 minutes of brushing your teeth to breathe and just set how you want to feel for that day. Like try it's so simple, but you notice a difference because the days I don't do it,
You notice that
I
it's
get knocked
not the
around,
same.
yeah, much more than other days where I'm like running around like a chicken with my head cut off, but I'm cool, calm, and collected while doing it. It's great.
Yeah, a girlfriend suggested last night that I like try and document things. She was like, you should maybe do like a video recording or like document how the day is going or what's happening.
Yeah.
So I tried that this morning. That was like the first time, like because I don't do video,
Yeah.
like audio text and all that fun stuff. So yeah, so I tried that this morning to just kind of
I think this is so cool. I know an elected official now. Look at this. That's so cool.
yeah.
What do you want to do? Like, what's your goal of having this position for your community? Or do
So
you have bigger plans like to even go higher for, and this is kind of like a stepping stone for that journey?
no, it's not a stepping stone. Actually, this was not on the horizon. I was on the school board the last 8 years, and it was not in my like, it was not my plan to do this, running for like this position until I was talking to the current person and or the previous person, and she was just sharing kind of like ways that you can do good in that role. Because I just saw it as like, yeah, you're just kind of like a mascot, but you really aren't doing like what are you really able to do? Like what good are you actually doing? That was my
Sure.
concern. But there are things that you can do. So, I mean, really starting off is just kind of like rebuilding relationships because the last person just wasn't really engaged.
Mm,
So we have to try and like just
yeah.
help people to
You're
feel like,
starting from the ground up again to
yeah.
just rekindle that community. Good
Hmm.
morning, everybody who's joining.
Hello.
Happy Tuesday.
Good
Good morning,
morning.
Ashley.
Happy Tuesday.
Mhm.
I feel like my computer's just waking up. It like took me a second to even like press the link to come on here this morning.
Following in my footsteps. No kidding.
And you're usually like in transit, so this is like
I told you I planned ahead this time. I was like, I'm not in transit. I'm in my office. The train was on time. It's
Nice.
nice.
it's a miracle, really.
It's literally when things just go smooth without a hitch. Did you see Dr. Azar's patient who ran the marathon, the sickle
I
cell
did.
patient?
That was
Amazing.
amazing. Amazing.
I've
And
shared it with like so many of my patients because last week, even before the marathon happened last week, I had a patient who wants to be really active but thought that they couldn't. I'm like, no, you can. It's just a matter of building your endurance. Like we just learned of this warrior who's going to be running the marathon, and super exciting.
amazing. And I saw Dr. Minetti was there and
Yeah,
like
I
took
didn't
a
even know she was a
video.
runner. I'm like, that is so, it literally, I don't even know who this patient is, but it brought chills to and a tear to my eye. It was beautiful. Hi, Jennifer and Kenya.
Hello.
I figured we can give until like 9:05 for our stragglers. Sonia, did you draw that cat? I see the Sarkar hieroglyphics in
No,
it, or was that a gifted?
it was gifted. So we actually have someone that's here that works with us that is from Egypt.
Yeah.
And he had a friend that was traveling back and forth, and so he had that like made with my name on it and brought back from Egypt. So
That's amazing.
it
I
is
feel like I had a
beautiful.
past life in Egypt. Like all of that just speaks to my soul.
And I love cats, so it just works out.
Perfect. Ashley, do you want to share your screen for the presentation just for ease?
I
Or do you
can.
want us to do it for
Yeah.
whatever's easier for you?
I'm happy to do it. Everything's warmed up, so I think I think I have it. Look at me, Sonia. I'm so prepared today.
Yeah.
It's gonna take me 4 hours to get home. Like it's something like
No,
Murphy's Law, right?
We're not
Like
gonna say that. We're not gonna put
no,
that out there.
you're just gonna have a great day where
That's
like
right.
everything just goes as it should, and you're
And
gonna
we'll
be like,
continue.
wow, is this what life is like when it's supposed to be easy? We have our full moon tomorrow, guys. It's the biggest super moon. It's the closest to Earth. So time to manifest, release your fears, set your intentions into the world. All right, cool. So you want to kick it off with just the general housekeeping and whatnot, and then I can do Ashley's bio, even though we all know you, but I love to introduce my sickle cell APP extraordinaire.
All right. Okay, well, good morning, everyone. So excited to have our updates from Ashley on NASCC. So we have our Echo housekeeping, just asking that you have your cameras on, especially when you're speaking, mute your microphone when you're not speaking, and respect private health information of those that you might be referencing. We have our CME information, our accreditation and EOE statements. And then our disclosures for Ashley. And then we have the QR code that you can scan here, and we will put the link in the chat box for you so that you can get the CMEs. Thank you.
Awesome. Well, I have the pleasure to introduce Ashley, which, I mean, I don't think any introduction will be enough for you, but Ashley is the advanced practice nurse and program manager for the Division of Hematology at Thomas Jefferson University. She has over 14 years of experience as a hematology nurse and nurse practitioner. For the past 4 years, she's been the co-director for the Sickle Cell Advanced Practice Provider Opportunities, Resources, and Training, aka the Sapport program through the National Alliance of Sickle Cell Centers Advanced Practice Certificates program. She's had a lot of leadership roles within the sickle cell community, both at her current institution, also at Johns Hopkins. She worked closely with multidisciplinary teams to build infusion center models throughout the country through research and non-research pragmatic initiatives. She has a passion for collaboration with clinicians in the community to improve the number of individuals living with sickle cell that are provided high-quality, guideline-based care. So with that, I would love to turn it over to Ashley, who's going to just be giving us a little updates from NASCC. I'm not sure who all was, or it was a good turnout in Stowe, Vermont in this past July, but we want to make sure that everything's communicated to the ones who it's going to impact. So Ashley, I'm going to mute myself.
Perfect. Thank you so much, Maya, for that introduction. I'm going to talk today about really just some National Alliance of Sickle Cell Centers APP related updates, which, looking at the list of you, many of you have helped with this track or helped with the work group. So it won't be that much of news to you, but hopefully we'll continue to sort of move forward. Maya had a great introduction of me. I'm hoping you guys can see my, let me just see, big screen. You see the big screen? Perfect. These are my disclosures. None of them are relevant to this talk for today. And then today we're going to talk about the recent National Alliance of Sickle Cell Centers, or NASCC, annual meeting, specifically the APP track and some work that we've been working on over the last year, and then explain some new and upcoming initiatives and how you can get involved if you're interested. So for those of you that don't know, I think most of you probably do know, the National Alliance of Sickle Cell Centers, or NASCC, was established in 2020. It is a 501c3 organization, so nonprofit organization that includes over 110 comprehensive sickle cell centers, and it includes adult, pediatric, and lifespan centers. I have a link here in my slides that I'm happy to share out. They just recently updated their website in July, which actually has been great. I think it's a lot more user-friendly than the previous website, but has some consensus. It has where the member centers are, and who is sort of participating and who is caring for people with sickle cell disease. Every year, the National Alliance of Sickle Cell Centers has an annual meeting. It's a consensus meeting, and this past year was in Stowe, Vermont, as Maya was saying, from the 20th to the 25th. Some of the general consensus topics that were discussed across the meeting were the starting of transfusion guidelines, and then also gene therapy and who's sort of the right patient for gene therapy. This year was the first year for dedicated multidisciplinary tracks, and APPs had one of them, which was really exciting. But we also had a dedicated track for nursing, which Maya co-facilitated that group with Shannon Phillips. We had our social work group, psychiatry had one as well. It wasn't a formalized track, but they had started some increasing collaboration, as well as the upcoming sickle cell disease specialist. So this year was not just consensus topics, but had tracks specific to disciplines. And then we also had some combined sessions amongst each other. We had didactic and consensus discussions. Many of you were in the room, but for those of you that were not, we had leaders in the field that were speakers for us and also moderators. Many of you are here right now. So Jennifer Saunders was one of our moderators. We had Janice Nelson and Barbara Speller-Brown, Micah Furlis, Christine Takimonti, and then Erlisha Felder. And then we also collaborated with some combined sessions with Shannon Phillips and Maya, as well as Shirley Johnson from the social work group. So it really was dedicated for APPs, but we really tried to make it a multidisciplinary approach and collaborate with one another. Our didactics this year were building a transition program, research for advanced practice in nursing. We had a combined track there, expansion of services. We got to see Dr. Nelson's amazing clinic in Connecticut and what they have done for their sickle cell warriors. We talked a little bit about the Sapport training program and what data we currently have. We had a complex care panel of APP experts talking about their experience in their clinics and the role of APPs, as well as a multidisciplinary session of the care of the complex patient. We did have starting discussions about consensus around APPs, about what the role is of outpatient versus inpatient and combined roles, as well as talking about leadership and advancement. And it sparked a lot of really great conversation. We had started some of this conversation at last year's meeting in 2024, but really had some great dialogue and feedback from even more APPs this year than we did last year. So like I said, these were sort of the didactics for the track, as well as the consensus discussions that we talked about. In addition, we also talked about national certification and the support program and what that might look like. And I'm going to talk about the general themes that we discussed specifically for the consensus topics and sort of what the next steps are. Before that, I'm just going to give a brief overview for the support program, which I think most of you, just looking at this list of people here today, already know about. But for those of you that maybe don't know, so we established the support training program now into its 5th cohort, and it was to provide a focused postgraduate training opportunity for APPs that take care of people with sickle cell disease, so mostly NPs and PAs, to try to increase the nationwide workforce of APPs capable of providing current evidence-based care for people with sickle cell disease, and also to improve access for high-quality care. Again, established in 2021, we completed our 4th cohort in 2025, and then we have started our 5th cohort here just in September. This is the overview of the program. So we have knowledge assessments pre and post. We have a didactic series that's asynchronous on Canvas that includes benign hematology, inpatient sickle cell care, outpatient sickle cell care, pediatrics, and transitions, as well as some participation in AP-focused echoes, discussion boards, and then an observership. And then one thing we started last year, which we've continued this year, is having a new track for APPs with over 5 years of experience, where they would come into an accelerated track. And so we had a few people, just 2, that joined and completed the accelerated track last year. And we think I have now 6 that are in that accelerated track. And a lot of this accelerated track came from feedback from the 2024 National Alliance of Sickle Cell Centers meetings, with feedback about how do we get education, how do we get certification for APPs that have been doing this. Now that we are certifying working with the National Alliance to certify APPs, what does that look like for APPs that already have been in this field for quite some time? At the end of the completion of this program, they get a certification of the National Alliance of Sickle Cell Centers. So it's a certificate that they get from NASCC. But we've also talked, especially during these consensus meetings over the last 2 years, about what does that look like? What does that look like on a larger basis? How does accreditation look at the different accrediting bodies? And where do we fit on sort of the national landscape of things? And so we've continued to have that discussion amongst our internal support team, but have really gained a lot of feedback from the last 2 consensus meetings. We also talked a lot about consensus discussions around the roles, and there were lots of themes for each of the discussion topics that we went through. So we talked about outpatient, inpatient, and combined roles. And we really, as we went through these discussions, really felt like what's actually happening across the centers for APPs. Some of our roles can be really different depending on if we are in a standalone hematology division, if we're in internal medicine, or if we're in a hemonc division where we're seeing oncology patients and classical hematology patients. And so there's really a focus on, we really need to get the data before we can make any recommendations on sort of what the role of an APP should look like, and what best practice should look like. So those were the themes around the specific roles. We looked at and talked about national certification, and so specifically around the support program, what do we do for existing APPs that are already in practice? Should we legitimize it, and how would we legitimize it? What sort of area bodies should we go to? And we talked through some of the work that we've already done with NASCC and some other accrediting bodies, and how we can tailor it to the really specific work that we do. We talked about leadership and advancement, and how we can leverage existing resources or use what your organization already has. We talked a lot about collaboration and how do we know what everybody is doing, and how do we not reinvent the wheel. We talk through communication strategies and trying to keep people up to date, how we can stay connected. And if we have similar interests, whether that be clinical interest or quality improvement, how do we collaborate together? And then how do we collaborate on a larger scale with some of the other organizations, like Women and Girls with Blood Disorders, Bleeding and Blood Disorders? How can we use other national organizations and what they're doing, and how does that impact our patients and our APP and APPs that are doing this work? And how do we learn from it, and how do we continue to grow? So we established a work group, which we had started previously on a smaller scale before the last meeting. But we meet on the first Fridays at 12. We have talked through development of understanding a practice survey. So that's in the process currently, and going to go through sort of the necessary National Alliance of Sickle Cell Centers approvals before it goes out to the centers to really get a gauge and understanding of what practice looks like. So if you get the survey and you could complete it, that would be great. We are hoping to have some incentive to complete the survey. We're still sort of working through that. We also talked through mentorship and what that might look like from a formal standpoint and an informal standpoint, and if we should connect it through the support program for new APPs that are coming into practice. We worked through establishing communication networks and using existing networks. So some of the APPs weren't on the SCAPN network, and so we added them in for those that were interested. Shannon Carroll at Hopkins helped with development of a Teams page that we all can sort of collaborate through, and so we've used that as a pilot. And then this is a little bit of newer news that I was going to bring up at my work group meeting this week, is adding in an APP corner to the National Alliance of Sickle Cell Centers newsletter that comes out, and actually making sure that it actually goes out to APPs. It sounds like at the moment it just goes to center directors and maybe a select few, but how do we get information out about what we're doing and really try to increase that collaboration? So our next National Alliance of Sickle Cell Centers meeting is July 26th to 31st in Madison, Wisconsin. It is for members and non-members. We continue to talk through what the track will look like for next year. We'll continue to have conversations around consensus and hopefully have some of that information back about what's happening within the center so that we can make evidence-based recommendations about what practice should look like for APPs across the country in NASCC centers. So there's lots of work that continues to happen, and it's exciting. I think we've got some momentum, which has been really great. And if anybody is interested in getting involved, please email me. My shameless plug. But if you're interested in being a speaker at one of our sessions, or if you're just interested in getting involved in the track or the work group, please let me know. That is all I have.
Awesome. Thank you so much, Ashley. That was a great summary. And I think it really is a nice opportunity to get involved, because I think a lot of us, we just have our day-to-day of work. And when we think of just professional growth opportunities and whatnot, I think even in this Echo session capacity or at NASCC, there's a lot of opportunities for growth. And it's such a great environment, because I think we all are building up each other, and it's non-threatening. So any interest in involvement, presenting, just feedback, helping with the consensus, etc., please reach out to Ashley. And if you're interested in the support program, even though I think most on the call likely are involved in it, share it with your team at the very least. Perfect. So next, any questions or thoughts or comments, whether you've attended or didn't attend, or any questions for Ashley with regards to the support program or NASCC or the consensus in general? Awesome. All right, we'll move on to our case. So smaller group today. So if Kenya and Gabe, feel free to go off camera. We can keep it a little bit more casual today too.
All right, it's me again.
Doing hard work today. Thank you so much, Ashley. I appreciate you.
You guys can see my screen. I don't know why it's in this view, but it's okay. Is it okay like this?
Yeah.
Yes.
Okay. You can see everything at once.
All right. So this is a 49-year-old male with hemoglobin SS disease who was admitted on 10/14 to our hospital at Jefferson for recurrent priapism and sickle cell pain. Had not had any admissions in the last 30 days, but in the last year has had two admissions. One was for an insertion of a penile prosthesis and one was for priapism. Was admitted to the med-surg floor. I actually saw him in clinic last week. And his outpatient hematologist, Dr. Risk, his primary care provider is Dr. Axelrod, was having pain in clinic to his groin without priapism, but and doesn't have usually chronic everyday pain. He is not on any long-acting opioids, and he typically takes oxycodone 5 milligrams, but takes it really sparingly. He gets 15 tabs like every couple of months. Is on hydroxyurea, meloxicam. He's on Zofran, which he takes intermittently if he needs to take opioids, and then is intermittently on a bowel regimen of Senecolase and Miralax. Had not gotten any IV opioids. Does not have a history of acute chest stroke, DVT-PE, cardiomyopathy, pulmonary hypertension, renal disease, or iron overload. Does not have depression or anxiety or ovarians, substance use disorder, and no history of being in psychiatric care. He has been on hydroxyurea for many years and actually was started on it by Dr. Risk a couple of years ago when he was having more recurrent priapism episodes, and really had not had an event for years up until this penile prosthesis. And he actually was hadn't had any issues with priapism and was actually having issues with erectile dysfunction, which is what brought them to insert the penile prosthesis. So he came into the hospital and had some complications after the penile prosthesis where he actually had priapism, which in just the remaining tissue that they had sort of next to the prosthesis. And it was refractory to interventions and actually required him to be exchanged while he was inpatient on the 20th. That was his second exchange transfusion and his second ever transfusion that he had ever received. He had been transfused prior to the penile prosthesis that was placed in August. He does have a history of a Duffy A, JKB, and S antibody, but no history of hemolytic reaction, and he does have an active sample in the blood bank. Also, during his course of admission, he had some cytopenias, so he had a drop in his retic count and his hemoglobin, and then also had some thrombocytopenia, but that was sort of after the exchange. So his hydroxyurea had been held at discharge with the plan to repeat as an outpatient. His vital signs, when he came into clinic, his heart rate was 96, blood pressure 122/72, temp was 36.6, and then he was 98% on Romer. Baseline hemoglobin was 10 to 30, and his most recent hemoglobin on discharge was 8.8 with a hematocrit of 26.5. His white count was 4.3, neutrophil was 2.1, his MCV was 92, and his platelet count was 77,000, but it looks like pre-exchange he was like in the 200s. His retic count, as you can see, dropped from 2 to 2.9 and 41.5, which is when they held the hydroxyurea. And his hemoglobin electrophoresis, post-transfusion, his hemoglobin S was 16.5. His creatinine, 0.7, his Billy was 1.6, his urine toxicology screen was positive for opioids, which we are prescribing. He works full time, but he has been actually out on leave since his surgery in August, and due to the issues with recurrent priapism that he's had at home. He's really worried about losing his housing and healthcare benefits. He does have active insurance. And so it's just really just hoping to get some relief from the priapism. He has seen our team as well as urology. Urology had recommended doing another revision surgery to take out any active penile tissue, but he really wants to avoid another surgery. Previous to his last admission, we had talked about Adakveo and the Spartan trial and about trying to utilize that to reduce priapism. And he was willing to try that as an option before doing the revision surgery, but wanted to get some thoughts about any other recommendations from a disease-modifying therapy standpoint, and how do we support him going through this really challenging time where he's out of work, and this is usually a highly functioning guy that is normally not in the hospital. And I will just say that I just got his repeat labs in my box this morning, and his counts have now recovered. So his hemoglobin is sort of back up to baseline of 11, and his platelets have recovered, and so is his ANC. So we did plan to restart his hydroxyurea and then also do the Adakveo infusions, but hoping to get some input as well.
So just to summarize again, this is a 49-year-old with hemoglobin SS with the recurrent priapism, was on hydroxyurea. He's already had surgery and recommending another surgery to assist with this, but he's trying to hold off. So essentially trying to determine medication management and how to help from a priapism standpoint. First question I have, is this a new onset priapism for him, or has this been going on long term? Just because
So
49 is an interesting age if it was to just start.
So he had a lot of active priapism probably about 5 years ago, and then was put on hydroxyurea and had like no events, and then had erectile dysfunction. And so that's why they wanted to put the prosthesis in. And then since they've done the prosthesis, he's had all of this active priapism that he had not had previously. And
Mm.
most of it, like not requiring him to go to the hospital, like most of it he's been trying to manage at home, but it sounds like it's been like pretty like debilitating to the point that he like can't go in. And I was like, they put in a prosthesis, like, how can he be still having priapism? But apparently it's a very rare side effect. Like,
Yeah.
or like
I
adverse
have a
event.
lot of thoughts, but I don't want to over hijack. So Gay or Kenya, do either of you have any questions, thoughts, clarifications? I don't want to hijack, but I want to involve everybody who's on the call. But if you have any patients who had a similar type of case, or if you have any additional questions to kind of help guide this case, feel free to come off mute.
No, I don't have any questions, but I do have a patient, interestingly enough, he doesn't describe it as priapism, but like in his, the perineal area, like he has pain that comes and go, and it occurs, sometimes after sexual intercourse. So I don't know what to do with that, so I referred him to urology.
I actually had a
But
patient with that, and I'm trying to go back in my emails because there was a term for it because I had never heard of it before, but it was a similar, I might have to circle back with you and look in his,
okay, yeah, because
he
I've
had a
never
similar
heard of it
perineal
either.
pain, and it
Yeah.
was actually neurology. We had to send you for something else. I'll look back.
It's
Let
interesting
me write
because
myself a
he
note.
also, right, like, so he has like pain and like priapism, but then he also reports when he doesn't have that, when he doesn't have priapism, he has that perineal pain also. So it's
I
interesting.
wonder if that's like related to surgery, even like maybe there was some disruption with the nerves. Like for us, our general approach with priapism is we'll start with medication management and we'll actually use terbutaline first, just because it's such an old drug and it's pretty easy to get. So we'll start with that. And if that doesn't help, or I mean, first we'll just do Sudafed over the counter. If that doesn't help, we usually will escalate to terbutaline. If that doesn't help, sometimes we actually put on Proscar. If they don't have any contraindications. And then from there, if it's still ineffective, then we actually will prescribe Cialis or Viagra, which I always find funny since it has a box warning against priapism, yet this is what we're using to treat it. And then we have lots of patients who actually we teach to self-inject epinephrine to kind of give them the freedom. From a conservative standpoint, I've had a lot of patients report when they wear tight boxers or briefs when they go to sleep, that precipitates priapism. So that's like something minor that I recommend to our patients, because if that helps, not wearing briefs and all of a sudden the priapism episodes improve, like what an easy fix from that standpoint. The other thing where this isn't necessarily scientific, but it makes sense in my opinion, is from a physical therapy standpoint, the pelvic floor is connected to the diaphragm. And if there's any like pelvic dysfunction, laying in the fetal position with the knees up and doing like deep diaphragmatic breathing can sometimes help alleviate priapism, and just based on how the synergy works. So you just want to encourage like low and slow breathing. You know me, I'm always into the holistic stuff before we go to medication management. And then I have yet to do the Adakveo, because the one patient who had the recurrent priapism, of course, the first infusion had like the worst crisis ever. So I've heard of Adakveo potentially helping from a priapism standpoint. So if it works, I mean, how great is that? But I personally don't have any experience with that.
I have an N of 1.
Did it work though?
It did, but for that
Okay.
one person, I know. I did have one person that we tried it for and it didn't work, that we ended up putting on chronic transfusion therapy, and that finally was what sort of settled it out. But then I had another guy that we put on chronic exchanges, and he still, like, that plus hydroxyurea still had recurrent priapism. So
Because I'm wondering, the fact that the priapism is so much worse after the surgery makes me feel like, is there some type of outflow or some obstruction that could be impacting his blood flow? Because why is it like you have surgery now all of a sudden everything is worsened? And urology is saying that it's not, or it's just a known potential side effect from surgery, and their only solution is to revise the surgery
is
essentially.
to like, well, just to like take
Clean
any
it out.
to take any of that active tissue. And so I think they're working with it. Like, I was like, can we try any of the other like Cialis, those sorts of things? They're like, we've tried it. Like at this point, like we're sort of past that. They're like, we could try it, but I think it's not gonna be helpful
Improve.
here. So I think we're hoping for the best that like medication therapy is gonna work, and then he just really does not want to do surgery again. But I think ultimately when I spoke to the urologist, they felt like that's probably what's gonna be the thing that's gonna settle this out.
And activity too seems to be related. Like my patients know that like if they can do some activity before bed to help improve the blood flow, sometimes that helps after. So I would just go with the conservative approaches and the medication management. And then at least you can say you've tried everything that you did before going for surgery, but it's just frustrating because what if he goes for the revision and then it's the same thing after?
I know. But I think those are like good points too that I think we sometimes forget about, like with like the sort of holistic, but also just like practical things of like the diaphragmatic breathing and then the brief, like boxers versus briefs and those sorts of things. Like
Right. So
I think
simple.
I just feel like he would do anything, right? Like he would do, if I could tell him that it was anything besides surgery, he would be
But
floored.
honestly, I would recommend like have him do like before he goes to sleep, have him do some type of deep breathing activity, like do movements and stretching just to loosen the body, do the deep breathing and go to sleep and see does that make any difference? And it might not make any difference at all. But again, at least you're able to try out the conservative, try out the medication. So that way, if he does go for surgery, at least he knows that he's done everything in his power to improve. That's frustrating. I think priapism is one of like I have a handful of cases, and the ones that are just not responsive are it's so challenging. Like at least he's 49, so he doesn't want to have kid, or I'm assuming, but at
Yeah.
49, I don't know where he's at in his stage of life, but it's like even worse when I have like my 20 and 30-year-old patients where I'm just thinking like, oh my God, there's probably so much scar tissue that what's fertility and family planning going to look like for you?
We actually did
Question,
send
you
one of our
guys.
young.
What's
Oh,
that, Kenya?
Quick question. My clinic is super small as we're getting started now, and I have about 3 patients with active priapism who are getting a Adacvio, and it really seems to be helping them when they miss it for whatever reason. They have episodes
An
start
episode.
again. And so I don't know. It's been working for me.
So now we're at an N of 4 where it works. So we're increasing.
Yes, yes.
Kenya, how long did it take for you to notice the improvement? Like, did it take 3 to 6 months, or was it a pretty
Yes,
fast on?
yeah,
So
yeah. Now, I did wonder about his age. It seems like he started later in life having these episodes in general. And most of my patients, they started like really young in like either children or tweens. And then I have a few other ones that aren't active. They just kind of grew out of them somehow in their late teens. But he does seem different from all of my patients that, it sounds like he didn't have it growing up, and it was just in his maybe 30s, 40s that he started getting it. Did he have any trauma ever?
Physical or mental?
Both, maybe.
I don't believe so, but it's a good question.
But
yeah, you're right. That my experience is it's usually like the 20-year-olds, and it seems to like settle out in the 4th decade. But yeah, no, it's a good point, Kenya, about trying to sort of explore if there's other causes.
Yeah, because even like testosterone, I mean, it just seems like the surgery definitely is what kind of exacerbated it. But given his age, yeah, I totally agree. Ruling out even medication or like supplements even, or if he does any recreational drugs. Could do. I mean, even they say alcohol and marijuana could.
I know. All I had was opiates
Just
and
in case.
UDS. I know. I'm just putting in the Spartan trial into the chat, and I'm just looking because there were 36 people. I'm looking at the age ranges of it was 18 to 40 was who was enrolled in this in the Spartan trial, which is the crizanlizumab. I think that's the phase 2, looking at crizanlizumab and priapism. And they had 36 people that were enrolled, and it was between 18 and 40-year-olds. I did have one young gentleman that we actually ended up sending to transplant. And ultimately ended up being cured and didn't have priapism anymore. But
Did he have any like fertility issues or subsequent issues? I guess if you're getting bone
well,
marrow,
we
you're
did,
getting,
but
like,
we did like fertility preservation.
fertility.
We did do that.
How does that work? Like I always wonder, because for the fertility preservation, even for gene therapy, it's like that's only one piece of the puzzle. How long is it going to cover it for? And then when you think of like, okay, now you have everything preserved and now you're going to do IVF, IUI, surrogacy, whatever, who's paying for that?
I know it's very true.
Yes, it's lovely.
I know.
Well, I thought this was a lovely presentation, and thank you for the updates, Kenya and Gay. Thank you so much for joining us. A little close and personal. We'll have to figure out how we can expand our reach and marketing aspects so we can get a more robust turnout. But please feel free to share with your staff and friends and colleagues. If either of you are ever interested in presenting either a case or a presentation, it's great to add to your CV. And again, I think it's a really non-threatening opportunity because it's only a 15-20 minute presentation with Q&As. If you have a presentation and want to tie a case into that as well, there's a lot of opportunity. So I definitely encourage it. Get your feet wet a little bit. The CME link is up at the top. So if you want to register for that, our next, Sonia, do we have a flyer or a slide for the upcoming Echo sessions?
We do, yes. I actually stopped just short of sharing that earlier. So yes, let me share that with everyone.
Thank you.
Mhm.
Gay, I know where you are. Kenya, where do you work from?
I'm in Mobile, Alabama at Infirmary Cancer Care.
Okay, great. And are you adults or pediatrics? Or both?
All adults.
Okay, great. Oh, nice. The ketamine presentation. I'm very much excited for that. I hope I can sneak away. Those Thursday ones, it's so hard for my clinic, but it's cool.
I know. And then we have Dr. Jones with the
Dr.
type and
Jones.
scream blood banking next month. So
It's an important
Good.
one too. Awesome. So we hope you guys can make it. We'll give you guys a little time back on your Tuesday. Ashley, Sonia, thank you as always for doing this with us. Kenya and Gay, thank you so much for joining. We appreciate your commitment to expanding our knowledge base and professional development. So with that, I hope everybody has a wonderful week. Make sure you prioritize self-care, get some sunlight, do your deep breathing, and set your intentions.
Okay,
And with
Maya,
that,
please
tell
don't
me.
forget to give me what that condition is because.
Yes, I put it on my to-do list because I'm going to look in
Okay.
his clinic note and I hope I can find the name because I had no idea. I still remember because when he was describing it, I'm like, I have no idea what to make of this symptom and sensation, and it made no sense. But yes, I will
You
look back. in his-
originally sent him to urology and then urology sent him to neurology, like, because you said he saw the
I'm
neurologist.
pretty sure it ended up being neurology. So I might misspeak. So let
Okay.
me go back because this was like over a year or two. My years are blending, but it's well over a year ago. But I have it on
Okay.
my to-do list for you. I'm opening up. I have 2 medical records. So I have to open up the second one. But let me look in his note and I'll send your email.
All right,
My
thank
happy
you.
email. Awesome. Happy Tuesday, everybody. Have a great week. And congratulations again, Sonia. In case you guys didn't know, Sonia, can I brag for you?
Okay, it's a small group, so okay.
And it's a big accomplishment. You should be so proud of yourself. But Sonia, she was just elected as an elective official for her, what is it? I don't want to misspeak.
City council.
For her city council.
Oh,
So she's moving
congratulations.
up. She's making her impact, and she had to really like put yourself out there and promote and get nominated and voted on, etc. So very exciting. I love seeing people just exploring their reach and make a ripple into the world. So awesome. All right, Gay, I will send you an email hopefully sooner than later. I'm going to do that now
Okay.
before my day escapes me. Have a great week, everybody. Thanks again.
All right, take care. Bye.
Bye.